Dr. Ghassan Wahbeh, a key opinion leader in the inflammatory bowel disease. Many gastroenterologists and patients are interested in the alteration of the microbiota as a treatment for inflammatory bowel disease. What are your thoughts on dietary modification and interventions for patients with active IBD?
Well, as we know, there's been a huge interest in the dynamic of the microbiome and how that associates with the local immune system and the immune system at large in the body, and how that translates into the disease in inflammatory bowel disease. And certainly we've seen some strong evidence that nutritional therapy in IBD does deliver with induction with way better outcomes than steroid induction in the so-called conventional therapy. And I think equally important is to recognize that patients read into the knowledge about nutrition and IBD, and really there's a huge desire to use normal food, or what would constitute normal food, instead of any formula to control IBD. And I think it's important to recognize that interest, and it's important to apply what we know today about the microbiome and modulating the microbiome with different nutritional plans. At the same time, recognize the deficits in nutritional plans, the way they could be used without the best outcomes that we could deliver for our patients. So I think it's important to keep in mind that this use of nutritional therapies can be balanced to deliver really a wonderful outcome when it comes to induction of remission with the least side effects possible among the treatments, but also recognize that it should be coupled with a bigger plan to ascertain the best, deepest remission that patient can get.
And is this treatment strategy different for pediatric versus adult patients with inflammatory bowel disease?
In some ways it is. We recognize that the adolescent age group, where most of our pediatric IBD patients present, is a very difficult phase because a lot of body processes go on during that phase. However, if these are interrupted, and all of them are interrupted by IBD, then making up for that deficit in the future can be quite difficult and compromised. And I think that's why we have to be above and beyond sensitive to what these therapies are doing in terms of effects and deep remission, and also what they're doing in terms of adverse events that are particularly concerning for a pediatric patient. And at the same time, be very critical of where these therapies or therapy plans underperform, because that's really a great window of opportunity that we have for those patients with IBD presenting in childhood. And treating them in a certain way in the first year, maybe the first few months of diagnosis, could have a huge impact on how their course is down the road and how you manage them as adult IBD providers in the future.
And what about the role of fecal microbiota transplantation, or FMT, for either ulcerative colitis or Crohn's disease?
As we know, it's a hotbed for active research now. You know, there is a lot of data that is coming in about the results of fecal microbiota change. Now, manipulating the microbiome could be done with a process such as a fecal transplant, but it's hard to also imagine, and this is what a lot of the data are showing, it's hard to imagine that this acute change in the microbiome from a fecal transplant can be sustained without an environmental change for the microbiome. And that takes us back to diet. But it also takes us back to the immune system. I think we're seeing some evidence that there are certain genetic markers, certain enterocyte features, and certain immune cell features that perhaps dictate the balance of the microbiome. So I think it's more complex than just a matter of take out the microbiome and replace it. And it's a dynamic process where a lot of facets are playing in, and certainly it's an exciting time to look for what's to come from the research.